con khỏe. Lần này phát hiện bất thường tim thai từ thời điểm 25 tuần, sàng lọc trước sinh hay là khi là bình thường ạ?
Hôm nay anh không đi à? Thế anh cho anh chụp cái thẻ ấy, cho em xin cái mã được không? Em có vi phạm người đó. Sử dụng cái thẻ của anh ấy.
So the patient divided into a station and into a cardiac test. Please come closer to me. It's important when you're scanning to try and get the baby, to get the mother in a good position. So please come closer to me. Come closer. Yeah, that's it. Come close. And then this arm over your head, please. Yeah, thank you. And just lift it close. Come over to me. That's it. Thank you. Okay, I'm going to start the examination with an RM7C, and I'm going to go straight to a routine setting, not cardiac, but routine. And I start by working out the baby's head is down, and then I come up to the baby's bottom of the ears, the baby's legs, the spine is to the right, and then I sweep from left to right side, and I confirm that there's a heart motion present. So I have a baby that's in single life pregnancy on board. Before I jump to doing the cardiac evaluation, the next thing I want to do is to optimize my machine. So the first thing I do is reduce my sector width, and when I reduce my sector width, my frame rate jumps to 85. The next thing I want to do is to reduce my depth. And then after I reduce my depth, my next I want to do is to do a HG zoom. Once I'm in this position, I'm looking at the 4 chambers of the heart, and then increase my dynamic range. And then I go into my preset, I then select a map of what to choose, which is ice. And then in doing the evaluation, I confirm that the stomach is on the left-hand side, and I confirm that the heart is on the same side as the stomach. So I start off by doing everything examination size, axis, rate, rhythm, and cycles. When I look at the heart, I look at the 2/3 of the heart is in the left hemithorax, and 1/3 of the heart is in the right hemithorax. This is important in terms of excluding cardiomegaly. It's important to show that the stomach is on the same side, because babies with atrioventricular septal defects will frequently have heart and the stomach on different sides. When I look at the rate of the heart, I don't, just a moment, I'm not going to take a measure of it, but just eyeballing it, it looks like a normal heart rate. I look at the axis of the heart, I draw a line through, an imaginary line, through the interventricular septum, and I draw a line through the generic feature of this machine. And we draw a line through the interventricular septum, and then I draw a line through the anterior chest wall, and I look at the axis of the heart. When you look at the axis of the heart, it's normally 45 degrees, plus or minus 20 degrees. So I look at the heart, looking at the apex of the heart, it's got a normal axis. When I look at the position of the spine, the rate is normal, the size, axis, rate, rhythm, and cycles are all normal. My next is to move to the evaluation of the fetal stomach according to these guidelines. So the stomach, the descending aorta is to the left, the spine, the stomach is on the left, intrahepatic vein is like the letter C, and then the gallbladder is on the opposite side. The gallbladder, intrahepatic vein, IVC, anterior to the right, aorta, and stomach. So the very first section that I look at, and I'll say that to the singular, is a normal position. Why this thing was not set up for prospective this recording. Yeah, let's do this. I need retrospective. Do you want to set it up? So we just, I think it's important for your machines, and you set them up for connectivity and T2. You set it as a retrospective loop recording, and the advantage of that is retrospective. And then the advantage of that is that you have a save, it doesn't interrupt your scanning. And so the first T2, it records retrospectively. I separately have a USB stick in, which is P1, which records prospectively for teaching purposes. But in routine clinical practice, have a retrospective image, which is very important for reviewing your work later if there's an abnormality miss, that you have a silly look at the heart to go back. Next, we move to color Doppler, and on color Doppler, I see the J hook of the intrahepatic vein curving away from the stomach. It's telling me the baby does not have a consistent right umbilical vein. This is normal. When I could look at the aorta and the IVC and split my image in two, I can see the fill of the aorta, but the IVC is not filling, because my PRF is at 24 centimeters a second in the top left-hand corner. This is the IVC here. If I want to bring the IVC, I need to drop my PRF, and now my IVC, I can see the filling. I can see that the aorta to the left is fine, and the IVC is to the right. So this is a normal relationship between the aorta and the IVC. If I take off my color, I then go to the intrahepatic vein and a magnified image. I can achieve also to demonstrate this in power, not just color. But as I said to you, for looking at tiny vessels and flow, my preference is to slow flow, because it gives me very nice details of the tiny little branches looking at it. So I turn my slow flow off, take my menu, sub-menu, and then I split it to. I see my intrahepatic vein. I now need to bring down. I have no control on the PRF. All I have my control on is on the power output and the control on by looking at the gain. And I can see all the time the branches of the intrahepatic vein. I can see it curving. In the controls, using gradient flow, you have the option of changing gradient mid, and max. The general rule, I can choose max as my preference. So the section 1 of the cardiac evaluation according to VCO guidelines is normal. Next, I move to section 2. The section 2 of the cardiac guidelines is looking at the fourth chamber of the heart. The first thing when I look at the fourth chamber view of the heart, I see the pulmonary veins entering normally into the left atrium. And when I look at the AV valves, I can see only one AV valve, not two. So this one here shows the left, when the left up here and right. So this is the baby that's an AV valve. So if we unfreeze that, I then magnify the image, and this is golden rule number 4, cine loop. So I use the cine loop to rewind and to look at the point where the valves close. When I look at the interventricular septum, I'm seeing that there's dropout in the perimembranous portion of the ventricular septum, and also the atrium primum is missing. When you see a VSD, you see 3 things. 1, dropout. 2, edge enhancement, and 3, a color wash. I will come to color in a second. And the baby's heart, I can see that there is fluid around the baby. This is normal. When the measurement of this is less than 2 millimeters, but this is normal. When I'm looking at the movement of the valves, I'm looking into the chambers. This is the descending aorta, left atrium, left ventricle, right ventricle, right atrium. When I'm looking at the pulmonary veins entering into it, I can either use start looking at the pulmonary veins, and when I see the left atrium, then I start off by looking at color. When I look at color, there's too much color. I need to pull back on my power output, and then I need to pull back on my gain. I move after using power, my exit I'm going to use after color, I use power. For looking at the pulmonary veins, I look to look at power. So when we look look at this view here, we see the pulmonary veins entering into the left atrium. This is coming here and here into the left atrium. When I see the pulmonary veins entering into the left atrium, it excludes total anomalous pulmonary venous return. The other way is to look at slow flow. And when you look at slow flow, you need to turn your back around, put the background on, and with this you reduce your balance. And when you reduce your balance, you can see the pulmonary veins coming very nicely. Put this in here, multiply the image, zoom it up, you can now see the pulmonary veins entering into the left atrium. This is why I like slow flow, because it gives you precision of seeing these tiny little vessels, and that's why I like it also. The flow across on both the left and the right vein. You can also see, look here, that this is the descending aorta, which is to the left of the baby's spine. So, when we're in this position, going back to the four-chamber view of the heart, I'm just going to magnify the image of the heart. And when it's in this view, before the baby moves, I'm going to see if I can just stay to stick bottom in case the baby moves into a difficult position later. For this, I'm going to select 4D. I can select the acquisition time of 15 seconds, an angle of 40 degrees, and then I'm just going to get the position to get the baby's arm out of the way, with the arm is over the chest. And with that position, I'm going to stop breathing. And then I count down 5, 4, 3, 2, 1, breathing away. Well done. So when I take this volume, I'm just going to save this if the baby moves into a difficult position later. And I go to a multiplanar evaluation. I select my screen when I move up onto the A plane, and then I'll bring my DRSI up to a setting of 5. I can slow down my volume, and then I can translate, and here I have the main pulmonary artery, the aorta, and the SCC. And I will be looking at these in both 2D and in 3D. When I come down to looking at the four-chamber view of the heart, it allows me then to rotate around the y-axis and to look at very slow motion on the stick button analysis. You can, if you want to, then move into a rendered image on this. So we go translation to the volume. So this shows you a ADSD. You magnify the image, the ADSD. I'm just going to select my vicinity, my degree of interest, position my volume, and then start vicinity again. Remember, when you're evaluating a volume, ensure that you save your volume, otherwise you will lose it. And now I translate to my volume, and I can see my complete AD canal defect. You can also have, I've manipulated one. And you can change your light source around this, looking at your atrium ventricle. You come behind the heart, just here, the top left-hand corner. Your best light sources, when you do light source, is from 2 o'clock across to 11 o'clock. These produces, in general, when you're doing 3D imaging. Anyway, I'm sorry because I've jumped to stick volume. I want to stick to basics, but I just want to capture that volume while the baby is in a good position, and we can come back to this in a second. So, my next step, having done that, is then switch my transducer, and now I'm going to go to C2 to 9, and I'm going to see the images are better with C2 to 9. So as I come across, look at the four-chamber view of the heart, I want to check the moderation band, I want to check the ventricular septum, and then I turn down my, increase my acoustic output, slightly increase my gain. And my next step that I want to do is I want to do a cardiac, go to a color Doppler evaluation. So once I'm in this position with the four chambers in view, I can see the moderation band is inside the right cardiac ventricle, descending aorta, left atrium, left ventricle, right ventricle, right atrium. And now my next is to select power. When I'm using power Doppler and my preset jumps to 40 PRF, well, I'm going to increase my PRF up to 51 centimeters a second. And when I do that, I split my screen using Cinew. Do you want to get a fresh new mic? Just put it on because it's sometimes dropping out. When I look across, I can see that there's a regurgent jet in the center here. Yeah. So you can see the center of the heart, there's a regurgent jet in this fading of an AV canal defect. What you can do is you can simply play that cine loop, and you can take the cine loop and drop it down to 25% and see that the regurgent jet occurs exactly at the time of ventricular systole. And that's very important in the sense of monitoring the pregnancy to work out whether it's leaky or not. As a general rule, babies who've got complete AV canal defects tend to have less leaky valves than those with partial defects. And once you've got that, then you can save that cine loop, and you see on my clipboard that I have the cine loop saved, and this becomes important from the point of view of going back and examining the baby later. So I come out of this, go back to looking at the color Doppler in this baby, and the arm is in front of the chest, so I just need to push the baby a little bit. Sorry, please tell the patient if I'm pushing too hard. So my next I want to do is demonstrate the outflow tract. The baby is going for a walk. So the first I want to do is to look at the pulmonary artery coming out of the right ventricle. So I need to have the free wall of the right ventricle in view. So this is the free wall of the right ventricle, and once I have that, then I'll bring my pulmonary valve into view. So I magnify that in the jug. This is the pulmonary valve opening and closing. So I want to know the pulmonary stenosis, but this valve disappears completely. This is during ventricular diastole, the valve closes. This is during ventricular systole, where the valve completely disappears. There's just a little bit of the valve there, but in essence, the valve disappears. So as I sweep up to this, I then want to look at the TRvedC view. So as I look across here, I see just briefly, as I come across, I see the main pulmonary artery is larger than the aorta, is larger than the SVC. And I say the synergy of that to file as well. The next, as I come across, is looking at the TRvedC field views, and I look at the color Doppler on this, and I see, or first I see the TRvedC view. So I see here is the main pulmonary artery, this is the aorta sitting beside it, and then beside it again is the SVC. So this is called the TRvedC view, SVC. And I see the normal relationship of the vessels, which are perfect in their position, and I look at that in reference to the fourth chamber of the heart. And I see that the curvature of the vessels coming out is correct. So this is the right ventricle, and the curvature of the pulmonary artery is to the left. So this is normal. So then go back to the full screen display, and I go back to looking at the TRvedC field view, and I want to look at the trachea, and I want to look at the SVC. When I'm looking at the vessel that's closest to the trachea, this is the transverse aortic arch. I don't need to look at the fourth chamber because I know that's the trachea, that's the SVC, and there's forward flow in the aorta, and there's forward flow in the pulmonary artery. So there's no associated subsequent heart region. If I come back to the pulmonary artery, I can see the point where the pulmonary artery divides, getting off the branch, which is the right pulmonary artery, and the right pulmonary artery sweeps behind the aorta. The right pulmonary artery should be always smaller than the aorta. If the right pulmonary artery is, and if the right pulmonary artery is bigger than the aorta, then I need to be suspicious of tetralogy fallow or coarctation of the aorta. So the right pulmonary artery can either be big or the aorta can be small. But this is a normal relationship between these vessels. Let's see what else we can do. Is the next patient, do we have the next patient? I'll just do one more. So I have not got a left ventricular outflow tract, so I want to look at this. So I forgot to show you in the fourth chamber view heart that this structure here is the coronary sinus. So this is the coronary sinus on the inferior surface of the heart. So you go from the fourth chamber, and then you go down to the abdomen of the coronary sinus and come into view. And when coming up to the left ventricular outflow tract, you rotate the transducer and you demonstrate that the aorta comes out of the left ventricle. So this is section number 3, evaluation of the heart, so the LVOT. And you see that the anterior wall of the aorta is continuous with the interventricular septum. Make sure that there's no dropout. We need to confirm this in both 2D and in color. I also look at the caliber of the aorta to make sure the caliber of the aorta is correct. Okay. So in this view, looking at the left ventricular outflow tract, to make sure there's no aortic override, because ADSD with aortic override is a typical cardiac abnormality that exists with Down syndrome. And this baby has had amniocentesis though and confirmed that there is no Down syndrome. But do remember, if you see totality fallow aortic override, that you're not looking at it. So you can see as you come across here the opening and closure here of the aortic valve. And you just make sure that the valve disappears. This is the valve, it's in the center. So when we look at this here, that this is the aorta arising out of the left ventricle, and when you look at it, you see the valve is in the center. If the valve is close to the wall, then that's typical of a bicuspid aortic valve. It's also this view when looking at the left ventricular outflow tract, if you look to see that there's laminar flow in the aorta. And looking when there's laminar flow in the aorta, I split the image into 2D and a color. I pull back on my gain, I increase my dynamic range, and just sharpen up the vest coming out. If I'm seeing there's too much bleeding across the vest wall, then I increase my TRF, and I pull back on my color gain, and I get tighter flow of the aorta coming out of that ventricle. So that's that particular outflow tract, okay? Does anybody in the audience want to ask any questions before we move to the next issue? We're just going back to show you that in summary, if we go through the sections of the heart, we have a position of the stomach, the hepatic vein, come up to the four chambers of the heart, demonstrating the pulmonary veins, the symmetry of the atrium, the symmetry of the ventricles. So the four chamber, the common AV valve, left ventricular outflow tract, the aortic valve, right ventricular outflow tract, two vessels, the PLD, one the vessels. That's going through the section analysis of the baby's heart in the baby with a complete AVSD. Remember with complete AVSD, the strong association with Down syndrome and other chromosomal abnormalities. And therefore, in a situation where you are seeing this, you then go looking at the profile to see if you can see a nasal bone, because you know the association of nasal bone hyperplasia with Down syndrome. You can, when you're looking at this, you can take a record image, so you can just ask the mother to stop reading. When you look at this, you can see the red image of the fetal face. You come across. You can magnify, when you magnify this image, you can send it in the screen of view, pull back, take upwards, and then edit with your light source around from 2 o'clock around to 8 o'clock. You can get into this and then you take it to the sleep render in this machine. Where is the sleep render? HD live skeleton. HD live skeleton, tissue bone, HD skeleton. So yes, on this section of the HD skeleton, you can look here first of all at the nasal bone is present on the right and left side as an option, and then the other option you can look at is this one. This you can put back on your game, might have the echoes, and then increase your silhouette. And as you as you come across here, you can see your nasal bone in that rendered image. So these are the options in terms of looking at the baby. Another one here, the shape of threshold. The bone here on the left and on the right hand side. We'll save that image for the mother. This is also just to explain one other thing just to try is the baby, the linear 9. I don't think the linear 9 is going to work, but I just want to give it one go. And the advantage of the linear 9 is that it can just give you some extra detail. And also one other thing that I want to do is I want to examine the baby with the apex of the heart at 6 o'clock to see whether this is complete or partial. So look at the linear 9 and hit augment. You can see that gives you a little bit more detail of the moderator band, gives you a little bit more detail of the movement of the atrioventricular valves, and also it shows more clearly the edge enhancements that you get, telling you that there's a ventricular receptor defect from here to here. So there's a contiguous septal defect from here to here, and missing here is the atrium primus, which is not present. Good. Looking at the linear line also in this lady, you can see the pulmonary valve, it's very normal, important to make sure there's not pulmonary valve stenosis. And last thing to do, if I'm able to get it, when looking at the AE canal, try and get the baby's heart into a transverse position at 6 o'clock. And once it's in this position at 6 o'clock, then what you do is magnify the image of the heart, increase the gain, and then rotate 90 degrees, and then come up to see if you can work out. Alright, move. So get a 4 degrees the heart in the canal, try and get it to try and get it to the apex of this baby is very, very active. No. Okay, bring it to the next stage, I think. She's there. So now I've got the short axis. So we come across, you see the left and right vertical, and then we come up to the level of the AV valve, and now you can see it. So if you look here, this is the point here where the valve opens with the common AV valve. So this tells me for sure that I'm not looking at a partial AV valve defect, I'm looking at complete. So I come up on the short axis, and then slowly come to the point where you see the valve, and there's the common AV valve. Okay, get the next patient. Thank you very much.